Welcome everybody to JACC Journal Club. Today we have some special planned, but for those who don't know, JACC Journal Club is something we've been doing since last year. I'm Vivek Kulkarni. I'm the education editor for JACC. We have been having these online webinars where we review recently published articles in JACC and talk about important implications with the discussants that are involved in publishing the papers. Today we're actually going to be not talking about a research paper, but talking about the new 2025 ACS guidelines. Before we get to that, this is a CME accredited activity. So for those of you who get continuing education credits, this qualifies. As a result of that, I need to display on the screen several mandatory slides for getting continuing education credit. You do not need to read these slides, nor do I need to read them out loud, but I have to put them there so we can have them there. Credit statements, disclaimer statement, disclosure and conflict of interest, planner disclosures, faculty disclosures, and final statement about claiming credit. Okay, so today what we're going to be talking about is the new 2025 guidelines for the management of acute coronary syndromes. These guidelines are collaborative multi-society guidelines, as you can see here. The little QR code at the top right will link directly to the guidelines. For whatever reason, when my computer generates QR codes, it makes dinosaur, so I apologize for that, but hopefully if you want to follow along, you can. When the guidelines were published, Harlan Krumholz, who's the editor-in-chief of JACC, has decided, and I think it's a great idea, to think about guidelines a little differently. This is a quote from an editorial that he had in the article that accompanied the guidelines. Guidelines should not mark the end of a process, but the beginning of a broader public conversation. They deserve to be read, debated, taught, and when appropriate, applied. They also offer a unique opportunity to spotlight gaps in our knowledge and the urgent need for new research. Along with that issue, some of you may or may not have seen, there was a JACC focus issue exclusively focused on the guidelines that not only included the guidelines themselves, but lots of interesting and useful commentaries about different aspects of the guidelines, controversies, backgrounds, perspectives. If you get the journal in paper, you would have already gotten that. If you look at it online, this is all available online. The JACC Focus Issue 2025 ACS Guideline Spotlight. Again, the little dinosaur QR code will take you right to that website. And what it'll have there is all the expert perspectives, commentaries that are associated with the guidelines, talking about interesting parts of them, the guideline documents themselves. And then over on the right side of the screen there, you can also see there are podcasts, there are video interviews. It's really a tremendous effort to really dive deep into the guidelines and what they mean. I'll say as a clinician and an educator, I find this extremely useful. So I would highly suggest you check it out. And a lot of what we're going to be talking about today is based on some of the commentaries that were in that spotlight. When appropriate, we'll include links and QR codes so that you can follow along with the commentaries as we're going. I'm happy to welcome today's discussants. Our discussant today is Dr. Sunil Rao, who, every time we do this, the people that I introduce have so many titles and accolades that it would take me a long time to do it formally, so I just don't. And instead, I'll say Dr. Rao is Director of Interventional Cardiology at NYU Langone, as well as Deputy Chief. And more relevant to our discussion here today, he was the chair of the Guideline Committee for the 2025 ACS Guidelines. So Dr. Rao, welcome, and thank you again for being here.
Yeah, my pleasure. Thanks for having me.
So the way that we will structure the evening, basically just a discussion where we get to pick Dr. Rao's brain, and I'm very excited about that. We will have some questions for the audience that will be mixed in. These will be polling questions. A poll will pop up on your screen. We'll ask you guys to submit your answers, and then we'll go from there. And then at the same time, at the end of the session, we'll be doing a chat-based Q&A. So all along as we go, feel free to type questions into the chat, and we'll curate those. And depending on how much time we have toward the end, we'll address at least some of them. This is our first time using WebEx for for this session, just when you put questions into the chat, make sure that it says to everyone, and then that way everybody can make sure we see your question. All right, so the first topic, some softball questions, but I'm really curious about this. Please describe the process of writing a guideline. Most of us will never be involved in guideline writing. How are committee members chosen? What about conflicts of interest? And the last question is the one I'm really genuinely curious about. How on earth do you find time to do this? So I would love to hear you start talking about all this.
Yeah. Thanks for those questions. So there is a process actually for updating all of the guidelines. There is a schedule, and there is a continual surveillance of data to see when a certain guideline should be updated. So the Joint Committee on Clinical Practice Guideline is a joint committee between the ACC and the AHA. Currently, Catherine Otto is the chair. I'm the chair-elect of that committee, and it oversees kind of the entire guidelines writing process. So there's a schedule of guidelines that are going to be coming out. So the committee choosing process, I think, used to be less desirable than it is now. So I think there are going to be open calls for people to apply to be writing committee members. Whereas in the past, I think it was kind of largely left to the chairs of each writing committee to decide, kind of which partner societies, which specialties should be represented. Partner societies, usually representing kind of stakeholders in that particular disease state, are allowed to nominate writing committee members. So for example, for the ACS guidelines, we invited 7 societies, 5 responded, STS and AATS did not respond. And so the other 5 societies had writing committee members that were part of the writing process. There's also a peer review committee that peer reviews every guideline. For the ACS guidelines, we underwent 2 rounds of peer review. I think we got something like 250 comments that we had to respond to. And again, that peer review committee has representation from different professional societies. For the ACS guideline, because we felt that the patient journey, started in the ED, we had the American College of Emergency Physicians, the National Association of EMS Professionals involved with Interventional Cardiology from SCAI, obviously ACC and AHA. Patients are also part of the writing committee now, which I think is really an invaluable sort of perspective. I remember when I was part of the revascularization guidelines, we were debating the nuances of a trial and kind of deciding, trying to figure out what class of recommendation should we give it, because, certain endpoints were positive, others were neutral. And it was the patient that kind of piped up and said, having gone through multiple PCI procedures, this is what's important to me. And we were kind of, really sort of shocked back into reality about what's important. So it's been really, really helpful. As far as conflicts of interest, this is a challenging area, particularly for certain disease states. So for example, the valvular heart disease guideline. It's very challenging to find people who don't have relevant conflicts of interest. And what we're talking about here are largely financial conflicts of interest with industry. I think we all have to recognize that there are intellectual conflicts of interest that go into this process. And part of the challenge of being a chair or a vice chair of a guideline is to deal with those intellectual conflicts of interest. And even though there's an outline that's vetted, there are people who have dedicated their careers and their research careers to a certain topic, and they may feel that it's not adequately represented in that outline. And so try as you might, they might try to skew a certain writing section to kind of be reflective of their own interests. And so that's one thing that we have to sort of watch out for. The writing committee has to have, the majority not have relevant relationships with industry, so 51%. And then because each of the recommendations are voted on, if you have a relevant conflict of interest for a specific topic area or a recommendation, you're not allowed to vote on that. So there is a kind of a pretty vetted process of how that takes place. As far as the last bullet, look, everyone's busy. I'm sure everyone on the call is very, very busy. I guess I learned a long time ago that doing things that interest me doesn't make me feel like I'm busy doing it. So I really enjoy, what I do. I like doing research. I like being the editor-in-chief of Circ Interventions. I love being an interventionalist, and I really enjoyed being part of the ACS guidelines. So it didn't feel like it was something else I had to do. I mean, as a chair, I had at least a minimum of 2 hours of conference calls every week outside of the actual writing process. So it was a pretty intense time commitment, but I'm proud to say that the writing committee was really great. My vice chairs, Michelle O'Donoghue and Mark Rule, were terrific, and we actually brought the guideline in, within 14 months, which was the deadline that was given to us.
Well, thank you very much for walking us through that. And you for the attendees who may not know, Dr. Rao actually wrote a little personal reflection in that JACC Spotlight issue about the process, and I really appreciate it. One last question, just because I'm curious. Was there ever a moment where you were deep in guideline writing and got called away to do a STEMI?
Great question. So I don't know if I was called away to do a STEMI. There were a couple of times where I would have to text and say, I might be late. I'm just starting a case. And so that was where the vice chairs kind of took over. But I will say one thing. We did not have a single call that went over an hour. So we had an hour every week with the writing committee, and my goal was to get everyone to their dinner table on time.
That's pretty good. You should start running all the meetings, I think, from now on. All right, so now we'll start getting into the actual cardiology of the topic. So we're going to start with some polls for the audience. And like I said, it should hopefully automatically pop up for each of you. So we're going to start with this. Which P2Y12 agent is currently your first choice for DAPT? And obviously, this is in patients with acute coronary syndrome. Take a minute. Go ahead and fill out your answer choice. All right, take another 10 seconds. All right, so let's see what we get here. You can go ahead and end the poll. Okay, so I think we can see the results over on the right side of the screen. It's a little, the percentages are a little bit skewed, but I think the bar graph is pretty clear there. Among those who answered, it seems like ticagrelor is a clear majority, clopidogrel coming in second, and prasugrel in a distant third. All right, so that brings us to question 2 for the audience. Again, hopefully another poll will pop up here. In patients at high bleeding risk on DAPT, when do you currently, according to your current practice, de-escalate DAPT after an ACS event? And the choices are here: 12, 6, 3, or 1 months, or only when adverse effects develop. Again, we'll take about 20 seconds. Go ahead and put in your answer there. All right, so again, it's a little hard to see over there on the right, but looks like a pretty even spread all over the place. Some say 6, I guess the majority are 6 months or 1 month. Some people say 3, some people say only with problems, some people say 12 months. So that is why I love talking about guidelines. So, Dr. Rao, there were some updates to the DAPT recommendations in the current guidelines. I'll put them on the screen on the next slide, or a summary of them. Can you tell us about the decision-making process behind the updates? Couple of questions for those who don't know. The guidelines currently now recommend, the new guidelines recommend either ticagrelor or prasugrel, preferentially over clopidogrel, but not prasugrel over ticagrelor, which is at least mentioned in the ESC guidelines. And then the other question: why are there 2 class 1 level A indications, both for 12 months of DAPT and for de-escalation after 1 month, which seem a little bit contradictory sometimes? This is a figure not taken from the guidelines itself, but taken from an associated commentary, which sort of lays out in pictorial form the new guideline recommendations. So Dr. Rao, take it away.
Yeah, thanks. So I think this reflects kind of what some of the ground rules are when you're doing guidelines writing. And these are ground rules that have been established by the ACC and the AHA jointly. The first is you have to reflect what the randomized trials say. So if there's a randomized trial of 6-foot-tall redheads, you have to say, in 6-foot-tall redheads, this is our recommendation. So you have to be very, very adherent to exactly what the language of the guidelines is. The second is that you can't change a recommendation from an older guideline unless there are new data. And then, so what we're challenged with is what is the body of evidence, right? Because people do trials for a variety of reasons. They do a trial because they're really scientifically interested in the question. They may be really scientifically interested in the question, but they're trying to get a drug or device approved. They're not doing trials specifically for guidelines or necessarily to integrate or replace prior, strategies for treatment of a certain disease state. I really have to give a lot of credit to Usman Baber, who wrote the DAPT section. He's one of the world's experts, and I think really did a good job of summarizing the evidence. So to address the questions, why not prasugrel over ticagrelor? And we had a debate over this. It really came down to two things. The first was that while ISAR-REACT 5, which is the randomized trial that recommendation the ESC was based on, is an excellent study, it really is not, it wasn't blinded, and all of the patients in that trial underwent PCI. So remember, the prasugrel does get a class 1 recommendation in our guidelines, but it's for ACS patients undergoing PCI because that's how the Triton trial was really designed. It was not really designed as a medical therapy trial. Whereas ticagrelor was kind of an updated version of the CURE trial. CURE was that was when I was in training, where the median time to cath was 5 days. I mean, most patients are going to cath lab within 24 hours now. And the Plato trial kind of reflected that. Patients were randomized prior to going to the cath lab. So there was a distribution of patients in terms of the treatment. Some got medical therapy, a lot got PCI, some got bypass surgery. And so I think those are the reasons why prasugrel didn't get a preference over ticagrelor. And so ultimately, you have options as someone who's taking care of a patient with ACS. If your patient doesn't have any contraindications and they're undergoing PCI, then prasugrel is a very, very reasonable alternative. If you're in a situation where you want to load people upstream of the cath lab, ticagrelor is a great alternative. Or if you think that a patient is going to ultimately get medical therapy, ticagrelor is a great alternative. With respect to the recommendations around longer-term therapy at the time of discharge, it's analogous to the parenteral antithrombin therapy recommendations. So multiple agents get a class 1 recommendation because the trials just simply didn't, compare everything, right? So the foundational therapy for DAPT is still 12 months, and even the ESC guidelines reflect that. But we do have one trial, Twilight, that's compared kind of de-escalation at 1 to 3 months to ticagrelor monotherapy versus 12 months. So it's one trial, very well done. I think the result is very clear. So when you stack the body of evidence around 12 months versus this one trial, we kind of felt like either one is a reasonable option for patients with acute coronary syndrome, which is why they both get a class 1 recommendation. Similarly, you can use heparin in the cath lab as a class 1. You can use bivalirudin as a class 1 in the cath lab. So we do give options for people who are treating ACS patients because there are multiple randomized trials that go into inform these recommendations.
No, that's great. Thank you very much. And just a couple of things to highlight again for the audience. So if the patient is not on chronic anticoagulation, the recommendation is either prasugrel or ticagrelor in most cases, and those are preferentially recommended over clopidogrel. So that's important to know. And then the question of whether to de-escalate or not depends on the patient's bleeding risk and whether it is considered to be important to reduce their bleeding risk. Great. Thank you for walking us through that. And we're not going to talk more about anti-thrombotic therapy for the rest of the talk. Let's move on to our next question, and hopefully a poll will pop up here. Question 3, do you currently use ezetimibe in addition to high-intensity statin in statin-naive patients with ACS? So if that's not clear, patient comes in with ACS, they've never taken a statin before, obviously you're putting them on a statin. Do you currently also use ezetimibe? Again, take 15 seconds or so. All right, let's see what we get. So mostly no. It looks like a 2-to-1 ratio of no to yes. So that brings us to the next question, also on the topic of lipids. In patients with acute coronary syndrome and LDL between 55 and 69 milligrams per deciliter, with apologies to anybody who's not in the US for the units, with LDL between 55 and 69 already on statin therapy, do we currently add additional lipid lowering agents? I'll give that maybe 20 seconds. All right, close to 50-50, maybe not quite exactly, but somewhat divided. So that brings us to topic number 3. How quickly and how aggressively should we optimize lipids after an ACS event? And also, real-world data shows that we're already failing to achieve target LDLs in many patients with ACS, even with the old guidelines. So the question is, how can we improve? On the next slide, while you talk about this, Dr. Rao, I'm going to show this figure. This figure is actually taken directly from the guidelines. This is the figure that is relevant to lipid-lowering therapy. And it's, as you can see, split into 3 buckets, depending on what the patient is already taking or their tolerance of statins. Go ahead, Dr. Rao.
Yeah, look, I mean, I think it's pretty clear that we need to be very, very aggressive about secondary prevention in general, and lipids are obviously the cornerstone of that. I think part of the challenge is kind of the way the QI metrics might be set up. I mean, right now, a QI metric is whether the patient is on a statin or not, right? And so it's becoming increasingly clear that simply checking that box that a patient is on a statin is not enough. So I'm a big believer in being very aggressive with lipid lowering, as I'm sure everyone else on the call is. The challenge that we have, as you noted, is that real world data in clinical practice show that oftentimes patients don't even get a repeat lipid panel checked in the year following an ACS hospitalization. So I think we've got a lot of work to do in the implementation of some of these recommendations, but we have a challenge in American healthcare, which is simply the fragmentation of our care. Now, there's a lot of consolidation happening around the country, that leave the debate about whether it's a good thing or a bad thing aside. But hopefully, with the sophistication of electronic health records, with the implementation of artificial intelligence, my hope is that we can take some of these decisions out of the hands of the physicians and just kind of automate it, because it's one less thing that physicians have to remember. And we know that it's beneficial. We know that there is a care gap. And if we can kind of focus on other things and just kind of automate the intensity of lipid lowering and the follow-up for these patients, I suspect that our implementation efforts will have gone a long way. I know that there are several health systems that are doing quality improvement projects to try and increase the rate of not just statin prescription, but actually meeting goal with the LDL. And again, I think that starts with making sure the patient has close follow-up. Yeah, so there are the guidelines, and then there's the implementation side of things. And I think it just is a reflection that the work isn't done when the guideline is written.
Yeah, I think that's a great point. There was also, I don't have a QR code for it, I apologize, but there was a commentary about shared decision making also in the JACC Spotlight. And in these patients in the middle, let's say, patients, this was in the question that we asked, maximally tolerated statin LDL 55 to 69. In the new guidelines, addition of a non-statin LDL lowering therapy is given a class 2A recommendation with the words "is reasonable." And I think that's a perfect example of how sometimes it isn't easy to figure out who needs what, but making a decision on a shared basis with the patient can be very helpful to figure out what to do. In terms of upfront ezetimibe in a patient not already on statin, that's considered a 2B recommendation, may consider.
Yeah.
I think there is a bit of a challenge there that most patients who come in with ACS who are not currently on a statin, generally they're not taking many medications to begin with, and already we're giving them a flood of new medications. May not be super excited about taking an additional one, but I think it is something to consider, especially some of the commentary articles in the JACC issue also mentioned the importance of lowering lipids very quickly when ezetimibe will help to do that. I'm curious, I'm not aware of any trial that looks at ezetimibe in combination with what we might now consider very high intensity statins initiated up front. is that the reason that it
Yeah,
doesn't have a
exactly. In fact,
stronger
that's
recommendation?
yeah, exactly. And that's some of the language that's actually taken directly in the guidelines itself. It actually mentions that. And again, we're sort of adherent to the ground rules of the evidence. And so um, when you start thinking about sort of going beyond what the evidence shows, you're really starting to get into expert consensus. And that's another challenge for guidelines writing committees is the lines between a guideline, a book chapter, an expert consensus document can be very blurry. And so that's another thing that the guidelines chairs and vice chairs have to do is to kind of keep people on task and make sure that, even if clinical practice has gone beyond what the evidence base is, we have to stick to what the randomized trials or what the published evidence says.
And I will say that even though the line between those things is blurry, it's in the eyes of insurers, it's often very clear. And so having a recommendation like this one in the middle will hopefully make things a little bit simpler when we all have to have our prior authorization conversations.
Yeah.
All right, let us move on to the next topic. So question 5 for the audience. Do you use a beta blocker for ACS currently in patients who do not have heart failure, who have a normal EF, and who have received timely revascularization? And for the sake of argument, let's assume revascularization was successful. We'll give a little more time for this one. Maybe let's give more like 30, 40 seconds, because I think people may need to think a little bit about this one. But the question is, do you currently use a beta blocker in these circumstances, or in this circumstance? All right, so majority are yes, 66 to 21. So I think that probably reflects practice in general that for the most part, we're all using beta blockers.
Yep.
But topic 4 I wanted to bring up. So this is taken from the guidelines. There is a class 1 indication, 1A, I should say, in patients with ACS without contraindications. Early initiation of oral beta blocker therapy is recommended to reduce the risk of reinfarction and ventricular arrhythmias. One of the commentary pieces that was in the JACC Spotlight was written by Sanjay Kaul. There's a QR code linked to it right there, who took a very different perspective on whether the evidence supports the routine use of beta blockers in otherwise stable patients. So my questions for you, Dr. Rao. Number 1, are beta blockers as good as we think? Should we really all still be using them? And I guess related to that, you mentioned the question of what do you do when you think something might be different than a previously published guideline? Maybe we could start there.
Yeah, so I think Sanjay's perspectives are really valuable, and obviously he's a brilliant thinker. I think that the challenge is when you read what he wrote, which I agree with, I think he's conflating kind of chronic therapy with acute in-hospital initiation. And that's kind of what the ABYSS trial looked at as well, which is chronic therapy in patients who have had a history of MI. So there is a little bit of a difference, I think, in what the guidelines are specifically recommending versus what some of these newer randomized trials are showing. So I suspect that in future iterations of the acute coronary syndrome guideline, they will have to deal with this particular topic. And differentiate between acute therapy versus kind of chronic therapy. And at what point do we discontinue beta blockers? So I do think that beta blockers are a valuable adjunct to therapy. But obviously, in the current era, we've got multiple other evidence-based strategies to reduce a patient's risk. They're probably, not as good as they were when we had nothing else. So I think that this is one of those recommendations, if I had to guess, is likely going to get downgraded. But I think one of your other questions that may come up is, when do we stop considering evidence for a guideline statement?
Yes, that was my follow-up question. So for example, you mentioned the ABYSS trial. That was not a plant, by the way. How do we deal with trials that are published after the deadline. So the Sanjay Kaul specifically mentioned the ABYSS trial was published after you guys closed the doors. How do we deal with that? Are there guideline updates? Are you guys looking for, is this just waiting for the next 10-year cycle? I mean, what happens now?
Well, unfortunately, it's waiting until the next update. And the next update won't be 10 years like it was this time around. It'll probably be within the next couple of years. Because if the evidence is accumulating very rapidly in a certain topic area, then the guidelines committee will say, wow, we've had multiple randomized trials. We need to probably just update the previous ACS guideline. So while there is a schedule, I think that it's flexible enough that there's an accumulation of evidence, a specific topic may be updated sooner than we expect. But we do have to draw the line somewhere. And it was true for beta blockers. It's true for colchicine. So we didn't consider the clear synergy trial, for example. And as a guidelines writing committee, you have to draw a line in the sand. And no matter how tempted you are to kind of reach back out to the committee and say, oh, this trial just came out at ACC, can we do a quick write-up on it? Well, the problem is it's not a quick write-up because you have to meet as a group. You have to discuss the evidence. You have to vote on the topic. It has to undergo peer review. So you're adding multiple months. And then again, during those months, there may be another trial that comes out. So it's just part of the weakness of the process or part of the limitation of the process. But hopefully with more sort of timely updates, as the evidence base changes, the guidelines will get updated more frequently. You may remember, some of the older people on the call may remember the old days of the focused update of guidelines. And those have gone away. And the reason they've gone away is that it actually led to a fair amount of confusion. So if there was a focused update, the natural question was, well, is this replacing the previous guideline recommendations? Like, okay, well, if it is, what about all the other recommendations in that document? Am I still supposed to do that stuff? So it just was too confusing to have a focused update. So instead, the timeline for updating has accelerated a bit from the past.
That's good to know. And then another more practical logistic question that I have. Do you and the rest of the prior committee have any role in updates going forward, or is it a fresh start with a totally new committee who looks with clean eyes? How does that work?
So that's a great question. I'm glad you asked that. So there will be a new chair and a new set of vice chairs. There may be people who were on the writing committee of this guideline who end up on the writing committee of the next guideline. The joint committee likes to have new people involved because I think it's really important. We need to cast the net wide. We want people to have skin in the game and really participate in the process. I will also tell you that it's highly likely that when the next ACS guideline comes up for renewal or for updating, I may actually end up being the chair of the Joint Committee on Clinical Practice Guidelines because it's a 2-year term. Dr. Otto will be finished next year. And when that happens, I will actually be completely recused from having any involvement in that ACS guideline because it's too tempting as a chair of a guideline and as a chair of the Joint Committee and a former chair of an ACS guideline to kind of play the heavy and say, this is the way we did it, this is the way you should do it this time around. Instead, I'm going to be completely separated from the process and let the new chair and the new writing committee do their work without interference from me, the old guy.
I'm sure in many ways that feels like a big relief to not have to wade back into this. Okay, great. So let's move on. And we'll go on to this question. Question number 6. Do you currently use intra-aortic balloon pump and or microaxial flow pumps for patients with ACS? And the question and the choices here, you can see balloon pump only, flow pump, at microaxial flow pump only, either depending on circumstances or neither. And this one may take a little longer. Maybe we'll give it a full minute.
I may have misformatted this question and it may not be working properly. So you may just have people drop A, B, C, or D in the chat for this.
All right. Thank you for letting me know that. Okay, if it didn't format properly, we will press on. If you guys want to put your choices in the chat, feel free. And and we can talk about it as the time comes. And we'll keep going. One other question here. Question 7, let's see if this one shows up the way we like. What is the practice pattern for vascular access for ACS patients in your institution? Again, I don't know if this one is working the way it's intended to, but the choices are radial first by default, femoral only if needed, femoral first for STEMI and critically ill patients, radial first otherwise, radial or femoral at operator preference, or femoral first.
And this one is working.
This one is working. All right, let's give this one about 45 seconds.
Someone wrote neither in the chat.
I suppose there are other arteries.
I guess so. Oh, I see. They've been neither for the previous question.
Oh, yeah, that makes a little more sense. Yeah.
Sense.
Okay, so it looks like primarily a radial first group, but there, 10% of people said something else, either femoral first for critical ones or operator preference. So let's talk a little bit about some interventional type things. So how do you think about MCS and vascular access? And I guess there's a couple of specific things that I'll direct you to talk about. The first one is on the role of intra-aortic balloon pumps, which is a recent change in guidelines. And the second one is the role of microaxial flow pumps, which is also based on a recent important trial. As far as vascular access, there's often concerns about, obviously, radial access has lower bleeding, and then there's lots of wonderful things about it. However, practically speaking, I think people often still have the impression sometimes that femoral access can be faster. Sometimes people have the impression that if you might need mechanical support anyway, then it's better to start with femoral access. So I'm curious your takes on both of those topics.
Yeah, so I can start with the vascular access piece. This was a carried over recommendation. Radial artery approach gets a class 1 recommendation that was carried over from the revascularization guidelines that were published in 2021, based on really multiple randomized trials in both the stable angina population and ACS, showing not only a reduction in complications, but in a meta-analysis of all the STEMI trials, including a negative STEMI trial, which is Safari STEMI, negative for radial, really a reduction in mortality. Now we can debate what the mechanism of that reduction is, but at the end of the day, there were fewer people that were dead in that randomized group. So I think it was pretty clear that we had to give it a class 1 recommendation, particularly in patients with ACS, because again, that's where the body of data are. I think your points about kind of decision-making in the heat of battle with a patient who's got a STEMI or a patient who may have, kind of SCAI stage B shock are important. And I think that's really where clinical judgment should supplement the guidelines recommendations. And I want to talk a little bit about the intra-aortic balloon pump recommendation, which is a class 3 no benefit based on the IABP shock trial. And the recommendation is specifically worded: routine use of IABP in shock is not recommended because there's no benefit. We all have had patients who improve with a balloon pump. I've had it. I'm sure everyone on the call has had it. But the key word there is routine. So in other words, if you've got a patient with SCAI stage B, C shock, or even D shock, if your only protocol for that is to use a balloon pump without transferring the patient for potential escalation of therapy, you might want to sort of reconsider, because the randomized trial evidence really shows no benefit of that particular strategy, with the limitations of the IABP shock trial, which I recognize. So again, the key word there is routine use. Similarly, with the use of the microaxial flow pump, the wording that we use for the class 2A recommendation is selected patients. And the reason is that despite the fact that the dangerous shock trial was kind of phrased as a routine use of microaxial flow pump, it really wasn't routine use. These patients were highly selected. They were more selected than they were in the IABP shock 2 trial or even the culprit shock trial. These were patients who, if they had an out-of-hospital cardiac arrest, had a Glasgow Coma Scale that suggested that they would recover. So, that's why the wording was used in the guidelines. So, how do I think about it in my own personal practice? I am a radial first operator. It shouldn't surprise anyone on the call. But if I have a patient in SCI stage, C or D shock, I think that the data really do support the use of microaxial flow pump. And we will generally, in our practice, use a microaxial flow pump in SCI stage C or D shock with single access. And for those of you who are not interventional cardiologists, the microaxial flow pump is a 14 French device. The sheath actually does allow you to place the coronary guide catheter in the same sheath as the support device. So that's single access, and that's kind of what our strategy has been.
That's good to know. I think that sort of brings me to my second question about procedural things that, there's a lot of variability, I think, in procedural practice patterns, more so than medications. I think some of that is about resources. Some of that is about provider experience. I'm just curious, when you're writing the guidelines, do you think differently about guidelines for procedural things? It's very easy to recommend a statin equally to everybody, but recommending a microaxial flow pump is very different. There's cost issues, there's access issues, there's provider issues. I'm curious, how do you think about that?
That is an incredibly insightful comment, and I really appreciate the fact that you said that, because it is unlikely there will be an update to the revascularization guidelines. In fact, the revascularization recommendations now are likely to be incorporated into chronic coronary disease and acute coronary syndrome. The guidelines really are going to be a disease state kind of set of guidelines. There's not going to be
just to be clear for the audience, you're referring to the revascularization guidelines from 2021 that are specifically about coronary artery revascularization, but not specific to any particular disease state.
Exactly. So there won't be an update to those. And that's really where a lot of the procedural guidance was incorporated. So how did we handle that? We really, again, went back to the sort of the ground rules. If there was randomized trial evidence to support a specific procedural technique, we felt, well, if there is randomized trial evidence to support this, then people should be doing this. So radial approach, intercoronary imaging, use of a lima for bypass surgery. So those kinds of things, I think, are things that in general have a very robust body of evidence. And I think we all agree that if you're doing these procedures, you really should be doing those things because the randomized trial data support that. Outside of that, you're absolutely right. There's a lot of nuances around how we deal with procedures. And that's really the purview of specialized professional societies like SCAI to put out consensus documents, to put out sort of technical documents on how certain things should be done. But for the guidelines as we're talking about them, it's really where there is a robust body of randomized trial evidence.
And I guess a related question, maybe a little in the weeds, but when the committee votes on procedural recommendations, is there a bias where procedural people get to vote, or is it everybody's vote counts equally? I mean, I'm a general cardiologist. I've never touched an Impella catheter. Well, maybe a little bit in fellowship, but does my vote count equally to yours if we're looking at guidelines for procedural things?
It does, actually. And I think that actually lends more credibility to the guidelines, because in a way, you're not bringing an intellectual conflict of interest to that particular vote, right? Because proceduralists, whether you're doing EP, cardiac surgery, interventional cardiology, general surgery, we tend to practice today based on what happened to us yesterday. So if I'm using a brand new coronary guide wire and I wasn't able to wire a side branch, I'm going to say, I'm never using that wire again. It just doesn't work. And that's something that we really have to avoid when writing guidelines recommendations. So in a way, your view on those procedural randomized trials is incredibly valuable because you don't have a stake in that, right? You don't have a personal stake in it.
That makes sense. And I'm glad that's on video now. I'll bring that back to the cath lab where I work. Okay, so we've got about 10 minutes left. So we're now at the point of doing our chat-based Q&A. So for those of you in the audience, if you have any questions for Dr. Rao, now's the time. Please type them in. We may or may not deal with all of them. We also had people submit some questions before the event started when they registered. So we do have a short list of questions offline as well. One thing that I'll start with one question because I can. I didn't put in a slide about colchicine, but there was a very insightful commentary in the JACC Spotlight issue by Paul Ridker about the role of colchicine and whether that is different in acute coronary syndromes compared to in chronic coronary syndromes and secondary prevention. I'm curious, Dr. Rao, your take on colchicine.
Yeah, so I have to disclose a conflict of interest here. I was on the DSMB for the Clear Synergy trial. And I think the Clear Synergy trial is an excellent study. It is very, very difficult to assail that study. And, we had, I'm at NYU, we had both Paul Ridker and Sanjit Jolly as grand round speakers. It was really fascinating to hear kind of their perspectives on this. I do think that the body of evidence around colchicine is much weaker after the Clear Synergy trial compared with what it was, previous to that. I also think that we have to be very careful not to use that to diminish the inflammatory hypothesis. So ultimately, the question is, which anti-inflammatory agent is ultimately going to be beneficial in ACS? And that's the question that I think we should be trying to address. Sort of digging our heels in about one agent or the other probably is not going to be productive. And I personally don't think that there's much of a role for colchicine, at least routinely in ACS.
No, that's great. That's great. So we'll start digging a little bit into the questions. There's some comments about ezetimibe up front. Sort of it depends and based on the goal. I think that is a valid point and something that we all need to take into account, that shared decision making matters a lot. It depends on what LDL you're starting with. There's a big difference between 71 and 103. Yeah. There's a more technical question here for ACS due to bifurcation lesions. Talking about DK crush specifically, the guidelines do not tend to comment very much on specific interventional approaches. Right. Was that by design?
Yeah, I mean, look, this is a very, very technical question around inside baseball for interventional cardiology. You actually can convert to a DK crush if you start with a one stent technique. You just crush the side branch stent. But anyway, the reason that we didn't comment on this is largely because there is no dedicated DK crush versus provisional or culotte or whatever, specifically in ACS patients. It hasn't been done. And so that's really probably more in the realm of an expert consensus document more than a guideline. And I will take this opportunity to comment that I never disagree with my good friend Mike Contos. Always agree with Mike Contos, and you'll be doing the right thing. So.
There was also a question which we didn't specifically mention: is do the guidelines vary in their DAPT recommendations based on patients that are over 75?
So just to remind everybody, it is a little bit of a black box warning, not a little bit, it is a black box warning to use prasugrel in patients over the age of 75. It's, you have to sort of decrease the dose to the 5 milligram dose, recognizing there isn't a lot of clinical outcome data with the 5 milligram dose. It's largely pharmacokinetic and pharmacodynamic. So again, if the patient is 75 or older, I would just avoid prasugrel because again, it's a black box warning. I think ticagrelor is perfectly fine in the elderly patient, but again, you have to make sure you do your due diligence and talk to them about prior hemorrhagic stroke and risk for bleeding. So maybe I'll take this opportunity to comment that we did not have a special section on quote special populations in this guideline compared with previous guidelines that have had that. And again, it was largely because unless there was a randomized trial in a specific population, we decided that it wouldn't be included as a special population in the guidelines.
No, that's good to know. That's good to know that, often we talk about, well, what about this population or what about that one? But it's good to know that that was a conscious decision not to have sections like that. Another important topic that we did not have time to call out explicitly is timing of revascularization for non-culprit lesions, either in STEMI or in patients with NSTEMI or non-ST elevation ACS.
Yeah, so thank you for that question. It's a great comment. So you're right, we didn't comment on that. The ESC guidelines do actually comment specifically and make a recommendation around, when that non-culprit lesion should be done. So there is a randomized trial of timing of non-culprit disease in patients with STEMI. Patients were randomized to either at the time of primary PCI or at some point during follow-up in a quote staged procedure. That trial showed a benefit of doing it all at the same time, but that benefit was driven by periprocedural MI, which for any of you who have participated in clinical trials or have done clinical events adjudication, you know that it's practically impossible to tease out in a reliable way periprocedural MI from the index MI. So that was a huge weakness of that study. Certainly don't mean that as a criticism to the folks that did the randomized trial. They really deserve a lot of kudos to do that, which is why we didn't comment on exactly when or give a specific recommendation, a strong recommendation around when the non-culprit disease should be done. In the complete trial, which is kind of the definitive trial that looked at this, the median time to revascularization of the non-culprit was, if I remember correctly, somewhere in the 2 to 3 week range, if I remember correctly. It could be done up to 45 days later, I think, if I remember correctly. I may, someone have to check me on those numbers, but it was, you could do it either in the hospital or at some point later on. Our current practice is that if it's a very, very high risk lesion, very severe proximal LAD, very proximal disease, we tend to do it before the patient goes home. If it's not, then we let the patient go home and bring them back, usually in a few weeks, to do that non-culprit disease.
Sure. We have maybe 1 or 2 minutes left, so a couple of quick hits here. Can you mention lipoprotein A? Is that the guidelines talk a lot about standard lipid management? What can we say about Lp(a) testing during, after?
Yeah, so great question. And obviously, it's going to be at the topic of a lot of conversations over the next year, because there are going to be some trials that are reporting out, clinical outcomes trials on lowering the Lp(a). But that's really why we didn't talk about Lp(a) in the guidelines. We just don't have randomized data to show that reducing, first of all, we don't have any agents that reduce it reliably, like PCSK9s do. Statins may actually increase it by a little bit, by about 10% in some patients. So we just don't have great randomized data around Lp(a) in the ACS population. Again, this is going to be an area that's going to be rapidly evolving, and I expect that there will be some recommendations in the next iteration of the guidelines.
That's good to know. Can you give us a couple comments on IV Cangrelor?
Oh, yeah, thank you. So IV Cangrelor did not get a strong recommendation, again, because the body of evidence around Cangrelor, remember they had sort of a negative trial, and then they did 2 trials that were positive, largely around interprocedural stent thrombosis, which is a relatively rare but consequential outcome. So, that's one of the reasons why it didn't get a strong recommendation. It's a very, very valuable drug, particularly because of its short half-life. And just for those of you who use it, you do have to keep in mind the transition from Cangrelor to the oral agent. There's some terrific papers written by Dominic Angelillo on how to do that particular transition. But by and large, there just hasn't been a lot of uptake, and it's a little bit curious as to why. I think if we were to split hospitals down the middle, 50% are loading with an oral P2Y12 prior to the cath lab visit, and 50% aren't. And there's sort of very little Cangrelor uptake, but it is a valuable agent.
Yeah, there is a mention in some of the documents about timing of planned intervention being more or less than 24 hours, and that impacting whether you load up front or not. So that's good to know. And then, we only have a couple minutes left. There's a lot of interesting topics in the chat, but one I wanted to mention was, how much do you guys agonize about the specific words in the guideline? One of the questions in the chat was, often the exact wording you use has a lot of implications on how people are judged, on how drugs are approved, on how procedures are approved, malpractice cases, all sorts of things.
Yeah.
So tell us about what that's like from the inside.
It's agonizing. We sweat over every single word, and that's where, because I wanted to get all these meetings done in an hour, I would allow a certain amount of debate around something, and then I'd say, look, we just got to make a decision. Is it going to be A or is it going to be the? Like, which article do you want to use? And if we couldn't come to a consensus, I would do an online poll. And we would do the poll through the WebEx platform, and we would say, okay, we're using the word the, let's move on. And that's the level of scrutiny that every word in the guidelines gets. And so every sentence was pored over, agonized over. I will assure you that we really didn't take any of it very lightly.
That's good to know. And like I said at the beginning, the vast majority of people will never be involved in this process, and so it's nice to hear what it's like on the inside. And these things, the guidelines often come out as sort of a gospel almost. And so it's nice to see how the sausage is made a little bit. That's going to take us to the end of our time here. So I just want to remind everybody, there's a lot more that we could have, but did not have time to talk about. I recommend you all take a look at the JACC Focus issue. There is a lot of very exciting and interesting commentary, as well as the actual guidelines themselves. There's some podcasts, there's some videos, there's a lot of good stuff out there. I, as someone not involved in the guidelines at all, I learned a tremendous amount by being involved in this and by reading it. Also, I'll say this recording of this event will be made available on our JACC Journal Club website, which they just put into the chat here. Usually takes a couple days, but this is also something that we're looking forward to doing. Dr. Rao, thank you again for being here with us. This has been a great discussion. I learned a lot. I hope everybody on the call did too. This was really fantastic. Thank you, everybody, again for participating. And Dr. Rao, we welcome you back anytime. Thank you.
Thanks a lot. This is terrific. Great job. And thanks to everyone for dialing in.
Take care, everybody. Have a good night.